and events to enhance professional practice of cancer professionals. IAIO brings you your virtual meeting secretariat, the exclusive suite to manage your meetings and events. We execute your concept, and together we bring the best of IAIO. Oncology Updates, our flagship series, delivers the latest insights on all categories of cancer, bridging the cancer research and industries. We bring you the latest innovation, therapeutics, clinical trials, and ongoing studies. Our annual Congress, Indo-Oncology Summit, unites world-class speakers and delegates, offering a premier platform for young oncologists to showcase their research, learn, and network. Encouraging cross-disciplinary cancer research is the need of our, so we bring you International Congress on New Frontiers in Uro-Oncology and Uropathology, one of the largest scientific program in India. IAIO's knowledge partnership with industries brings you sponsored CMEs to educate healthcare professionals on the latest therapeutics, ongoing trials, and clinical studies. Join as knowledge partner with IAIO to elevate, lead, and innovate. IAIO's Academy is the exclusive learning management system for you, where module and courses are designed for young oncologists looking at the need of next-generation cancer sciences, so that we build the capacity of oncologists for next decades. The IAIO Academic Council comprises a diverse group of subject matter experts from various oncology disciplines to deliver education through online classes in affordable prices with opportunities of academic grants. At IAIO, we believe every step of your clinical practice could lead to a new innovation in cancer care. We partner with clinicians in every step, for enhancing their practice information and patient data to novel research by transferring your treatment's methodologies into scholarly publication. Our global network brings researchers of similar interest for collaborative research and drive ongoing studies and decentralized clinical trials. IAIO Library and Resources offers a vast collection of scholarly materials to keep you updated with latest insights on best practice methodologies. We understand upscaling your knowledge is the need of humanity. Let's give a healing touch to the life of cancer patients and survivors through initiatives of IAIO Humanity. Our patient and public welfare initiatives are driven by IAIO Community. Our communities and networks bring together experts from across the globe, fostering an environment of collaboration, shared knowledge, and ensures comprehensive support across all branches of cancer care. Join IAIO's exclusive membership with Abode of Opportunities, where we believe in a world where knowledge drives progress in oncology. Let's shape the future of cancer care together.
Uh, Good evening, Abhishek sir. This is Roshni from IIO.
Roshni,
Uh, yes, sir.
Right, I think we have to wait a bit for the other panelists and the people to join.
Yes, sir. Yes, sir.
Probably we can start now. I think other panelists and the other attendees will join subsequently.
Yes, sir. So, a very good evening, everyone. Warm greetings from IAIBO, International Association for Integrated Oncology. I'm Roshni, and it's my privilege to welcome you all to today's Expert Insights session focused on lung cancer. Thank you for joining us this evening and being part of this knowledge sharing initiative. Today's session is thoughtfully curated to bring together leading oncology experts who will share evidence-based insights, real-world clinical perspectives, and practical decision-making approaches in lung cancer management. So now it's my privilege to introduce our program director of the evening, Dr. Abhishek Tiwari sir, consultant medical and hemato-oncologist from Regency Hospital, Kanpur. Dr. Tiwari has been actively contributing to clinical oncology and academic initiatives, and we are grateful for his leadership in curating this highly relevant scientific agenda. Dr. Tiwari, we are honored to have you with us, and may I request you to kindly take over with the opening remarks and context setting. Sir, over to you, please.
Thank you. So first of all, I would like to thank IAIO team for having this, put all the hard work on the background for making this possible. And I would like to thank all my panelists and the faculty members too. We have an excellent faculty members and a focus agenda right now, and which is aimed at a real world decision making from the lung cancers. We start from the early stage lung cancer. We move on to the updates in the lung cancer, and then we move to a complex real-world decision-making process from oligometastatic right away to the stage 3 lung cancer as well. So in this regard, let us proceed with our first session. I would like to welcome our faculty member, Dr. Satya, Dr. Nimesh, and Dr. Shamila. Hello.
Yes, sir.
Hello, Dr. Abhishek. How are you?
Hello, sir. I'm doing fine, sir. We start with you, sir, today.
Thank you. So India has also started his batting. It's the right time to start the session also.
Yes, sir. You are opening the batting for us.
I just hope I don't perform like Abhishek.
You just don't perform me like.
Not you, the other Abhishek.
Okay, sir. Right, sir.
So, thank you, sir. And as we are talking, like as of Dr. Satya Sarang Sarangi, Senior Consultant Medical Oncology from HCG Hospital, Bhubaneswar, is our first talk on a modern management of early stage NSCLC. Dr. Sarangi, the virtual stage is yours.
Yeah. So firstly, thank you to the organizers, Dr. Abhishek, for giving me this opportunity. And I would request to kindly put up my slides. Yeah, thank you. Can it be full screen?
We are sorry for the delay, sir.
No worries. Yeah, so the topic as it is written here, the modern management of early stage lung cancer. So I must say it's a very valid topic that has been chosen because in our clinics, in our practical experience, we hardly see early stage lung cancer. Majority of our practices on metastatic or locally advanced. But somewhere down the line during our practice, in single digit, I will say, I have encountered some early stage lung cancer patient. And so it is very imperative that we all should be aware of what are the newer techniques in surgical aspect, radiation aspect, or for systemic therapy is there in the early stage lung cancer. Next slide, please. So just to start with, what we define as early stage lung cancer in very plain, simple words, based on the AJCC 8th edition, stage 1 and stage 2, and some selected stage 3A comes under the umbrella of early stage lung cancer. So stage 1 is something that is, it can be divided as 1A, 1B, 1C, but it is usually limited to lung with no nodal involvement. Stage 2 is usually a little bit bigger in size, more than 7 centimeter, or it has spread to the ipsilateral hilar lymph nodes. And selected stage 3A1, that is the single station ipsilateral mediastinal lymph nodes that are resectable, comes under the purview of early stage lung cancer. Next slide. Now coming to the histology, like it is there for advanced setting also, here non-small cell and small cell are the two most common histologies, and among the non-small cell, it can be further divided as the adeno and squamous. Next slide. So if you see the incidence and survival, it's considered to be the most common cancer worldwide, both in terms of incidence as well as mortality. So because of its high fatality, because of lung cancer, it is very important that we detect this cancer at an early stage, especially through screening. Unfortunately, in the setup that I have worked in, we do not have a very valid or a proper systematic screening approach to detect patient in early stage. But nonetheless, things are improving, and at certain places the low dose CT scan are available nowadays, by which some high risk screening population like 30 years or more high smoking history, more than 55 to 74 years of age group are being considered for screening at some centers. So if you look at it, why it is screening and why testing and diagnosing the patient at the early stage is important, because if you see the stage wise, stage 1B, stage 2 and stage 3 wise, the recurrence rate and death is increasing as the stage is increasing, from 25% with stage B to more than 50 to 70% in the advanced stage. But historically, if you look at it, the survival outcomes for early stage lung cancer per se, even after with curative resection, were poor. And when the adjuvant platinum-based chemotherapy was added, it did make a survival difference that is of around 5% at 5 years. But still, there was a scope of improvement, which we will see in the subsequent slides. That was made possible with the addition of immunotherapies or targeted therapies in the adjuvant setting. Next slide. The picture in Indian subcontinent is also the same. Estimated new lung cancer cases is 72,000, among which the 66,000 were estimated deaths due to the lung cancer. And here, smoking and air pollution seems to be the main risk factors. Next slide. Okay, so before proceeding to the management or treatment, it is very important that we all should know how we should diagnose or evaluate, or we do the pre-treatment workup. So generally, in the clinics, it starts with the history and physical examination, followed by assessment of the comorbidities, weight loss, and performance status. Why? Because performance status and weight loss seems to be the most important prognostic factor. It is not only true for advanced, but also for early stage, because there could be a patient who could be deemed resectable by the radiology, but he or she may not be operable because of the comorbidities or any other issues. With imaging, FDG PET-CT scan seems to be the most common test that has been ordered by routine clinicians, with CT scan and brain MRI being mandatory for clinical stage 2 to 3. In terms of labs, CBC and LKFT is usually ordered. And another important factor here is the cardiopulmonary assessment, which we do it with the help of PFT studies, the FEV1, the DLCO, and the cardiopulmonary exercise testing, that basically labels the patient as operable or not. Because we know lung surgeries are morbid surgeries, so the patient needs to be absolutely fit to undergo these kind of surgeries. And not only surgeries, in some cases, maybe adjuvant radiotherapy and adjuvant chemotherapy in many others. Another important point here is the tissue acquisition. Usually, if it's a central tumors, then bronchoscopic EBUS or EUS is preferred, or if it's a peripheral tumors, then CT guided or ultrasound guided biopsies are being done. And mediastinoscopies is also important. In earlier days, more invasive mediastinal staging was done, but nowadays with the available of this EBUS and EUS, less invasive process are now available to correctly stage the disease by doing the assessment of the mediastinal lymph node. And the pathology and the biomarkers. So we usually do, after histopathology, we usually do a TTF1 staining to rule out the adenohistologies, and P40 for the squamous histologies, and followed by the EGFR, ALK, and PDL1 to decide regarding the adjuvant immunotherapies or chemotherapies, targeted therapies. So in brief, if you see the local approaches, then surgery is generally considered in stage 1, 2, and selection of stage 3. And radiotherapy is also considered in the inoperable stage 1, 2 patients, and as a definitive modality in conjunction with chemotherapy in the stage 3 setting. Surgery plus radiotherapy, both modalities could also be used in some particular scenario wherein there is R1 or R2 resection, or there is a stage 3 and 2 disease who had responded beautifully to the induction chemotherapy, or if it is a pan-cos tumor. Next slide. So regarding surgeries, the ESMO guidelines clearly state that surgery should be offered to all the patient, as it is the preferred modality for those who are willing to accept the procedure-related risk. In general, lobectomy is considered to be the standard surgical treatment of tumors which are more than 2 centimeters and that have a solid appearance on CT scan. Anatomical segmentomy is generally considered acceptable for pure ground glass or adenocarcinomas in situ with minimal invasion. Non-surgical techniques like SABR, that is a stereostructive ablative body radiotherapy, is also considered for inoperable cases for stage 1 tumors. There are some data from the STARS trial and the ROSELLE trial that in high-risk inoperable cases, it is considered to be equivalent to surgery. But if fit, then surgery is always preferred. And the dose of SABR should always be a biologically equivalent tumor dose of 100 gray, which is prescribed to the encompassing ISO dose curve. Next slide. So these are some newer techniques that has been added to the surgical discipline, wherein VATS or the RATS, robotic assisted or video assisted, are now been more recommended over the traditional open thoracotomy due to reduced pain, shorter hospital stage, and improved long-term survival. And for nodal staging, modern guidelines mandate that intraoperative systemic lymph node sampling or dissection should be done with at least 3 mediastinal and 1 hilar regions for accurate pathological staging. Next slide. So a very brief about the stage 3. It is a very heterogeneous population, and it usually requires a multidisciplinary approach to decide the sequencing of chemo, radio, the surgical aspect. In general, CTRT is considered to be the standard of care for the multi-station N2 disease, and for single station and resectable nodal disease, perioperative approaches of combining chemo and immunotherapy surgery can be considered for the selected cases. And these usually result in a 5-year survival of 20 to 25%. Next slide. Role of RT, just to complete the quorum, usually it is considered that there is no role of postoperative radiotherapy in R0 resected PN0 PN1 tumor as per the MA 1998 trial. For N2 involvement, there has been a subject of debate and discussion, and carefully selected patients may be considered with a shared decision making after understanding the benefit and the side effects of postoperative radiotherapy. So among the operable patient with stage 3 NSCLC, complete resection and adjuvant or neoadjuvant chemotherapy is the standard of care. And if you see the lung ART trial, it has shown that there is no advantage in DFS, but mediastinal recurrences decrease by half if you give postoperative radiotherapy. So the general dictum here is it should not be administered to all PN2 patients. But yes, if there is a margin positive, then definitely there is a case for giving postoperative radiotherapy. Next slide. So based on this modern techniques, surgical techniques, addition of immunotherapies and targeted therapies, if you see the survival have improved a bit, like for stage 1A, it is more than 80 to 90%. For 1B, it is 70 to 80%. For stage 2, it is 60 to 70%, and for stage 3 resectable it is 30 to 50%, which you will see. I will show another slide in my future slides from where this survival has gotten better. Next slide. So important modifiers for survival is the molecular profiling, whether the patient is EGFR or ALK mutated or not, whether we are using adjuvant chemotherapy or not, whether we are adding immunotherapy to the chemotherapy or not, adequate lymph node dissection, margin status, comorbidities, and smoking cessation seems to be the prognostic factors. Next slide. So now coming to the systemic therapy. So we know that earlier lung cancer was considered to be a single disease and was usually treated with chemotherapy. But with the advancement in the diagnostic field, we came to know that it can be divided based on the histologies, based on the molecular pathologies, and the PD-L1 expression levels. Next slide. So coming first to the adjuvant chemotherapy, and then I will explain about immunotherapy, and then I will end it with the adjuvant targeted therapies. So next slide. Yeah, so I was talking about this slide. So this was based on the AJCC 6th edition. In earlier days, here if you see for stage 1, the survival is around 55 to 67%. For stage 2, it is 25 to 40%. And with both local and distant relapse being the pattern of relapse, and distant being the more common. So in general, within 2 years of surgeries, more than 80% of relapses were occurring, because it was considered to be that there could be some micro dissemination at the time of surgery. So this was the rationale for giving adjuvant chemotherapy in early stage lung cancer. Next slide. So after 2 decades of research now, and with multiple trials called IALT, the JBR10, the ANITA, and the LACE meta-analysis, now we know that yes, giving adjuvant chemotherapies, which is usually 4 cycles of platinum-based 2-drug regimen chemotherapy, it has resulted in improvement in overall survival. Within absolute terms, it is usually more than 5% at 5 years. Next slide. So there, came the question, should all early stage lung cancer receive the patient, or there are some certain subset in the early stage that they should be receiving the patients? Next slide. So why there was this confusion? Because the IALT, the ANITA, the JBR10 and CalGB 9633 included different subset of patients in their inclusion criteria. Next slide. So the stage which are marked in red are usually considered for adjuvant chemotherapy, which is usually 1B, more than 4 centimeter, or to up to stage 3A. Next slide. So the choice of a regimen based on the JBR10 and ANITA, the most studied regimen was cisplatin and vinorelbine, which was used during the earlier eras. Carboplatin, if cisplatin is contraindicated, nowadays people do substitute it, but there is no positive study with carboplatin. We should remember this. Then so the other chemotherapy partners which can be combined with platinum, it could be vinorelbine, it could be docetaxel, it could be gemcitabine or pemetrexed for adenocarcinoma histologies. Each regimen has similar OS, but there was not sufficient power to detect differences between these other chemotherapy regimens. Some common side effects: for vinorelbine, it was febrile neutropenia; for gemcitabine, it was thrombocytopenia; and for pemetrexed, it was skin rash and myelosuppressions. Next slide, please. So a bit about the timing. When should we start the adjuvant chemotherapies? The JBR10 suggested that the randomized patient were within 6 weeks of post-surgery. ILT suggested of less than 60 days. The Ontario Registry of Canada showed that there was no difference actually if you start the therapy between 0 to 10 weeks versus 11 to 16 weeks. And if adjuvant RT is indicated, it should be given after adjuvant chemotherapy. Next cycle, or next slide. So these are some important guidelines: the ASCO, NCCN, NICE, and ESMO, all of which recommended the adjuvant chemotherapy in stage 1B, more than 4 centimeter, or for those with high risk like the neuroendocrine vascular invasion, more than 4 centimeter, visceral pleural involvement, or incomplete lymph nodes sampling should be considered. Next slide. Age per se is not a factor for selection, but yes, the comorbidities and performance status have been shown to have a detrimental effect from adjuvant chemotherapy. Because these patients, we have seen in our clinics also that they do take some time to recover from the lung surgeries. So the evidence of benefit from adjuvant chemotherapy has been established in patients with performance status 0 and 1, and very rarely with performance status 2. Next slide. So this, I think I have already explained. The ESMO recommendation is also in similar lines with the previous guidelines. Next slide. So now coming to the novel approaches like the targeted therapies and immunotherapies, we will see. Next slide. Okay, so now the consideration for integrating IO into the care of resectable lung cancer. So here it is very important. While we are reading the role of IO in early stage lung cancer, we should all understand there are 3 types of approaches which is there. One is only a neoadjuvant approach. Second is a perioperative approach, and third is the adjuvant approach. So these are some pros and cons. With the neoadjuvant approach, we have a shorter treatment time, better compliance. It allows us to assess the response. With the further therapy, there is a potential downstaging, better antigen priming, and early reduction of micrometastasis. Whereas with perioperative, we have some advantage of neoadjuvant, that is the eradication of micrometastasis, but there is always the risk of overtreatment for certain patients. With adjuvant, there is no risk of surgical delay, no increased perioperative risk due to preoperative therapy, complete pathological staging, but the treatment time is longer, which is also the case with perioperative. Next slide. Biological rationale, I think most of us are aware of how these anti-PD1s, the anti-CTLA4 drugs act. So basically, we need 2 kind of interaction: one of TCR with the MSC, and second the CD28 with the B7. But there are some natural breakpoints which are there called PD1 and CTLA4. Cancer cells usually use these breakpoints in order to evade the immune system. And if we can just block the CTLA4 and the anti-PD1 or anti-PDL1, then the T cell is allowed to recognize and attack the tumor system by removing the brake on the immune system. Next slide. So these are the trials. For neoadjuvant, we have the CheckMate 816. For perioperative, we have the Keynote 671, CheckMate 7070, IMpower 030, and AGN. And for adjuvant, we have IMpower 010 and Keynote 091. Next slide. So we have the FDA approvals for nivolumab with the platinum-based doublet in resectable lung in the neoadjuvant setting. We have the approval for atezolizumab following resection and platinum-based chemotherapy in stage 2, 3 NSCLC and PDL1 expression of more than 1% in the adjuvant setting. And for pembrolizumab, also in the adjuvant setting, which is supported by Keynote 091 trial. And here the approval is for NSCLC tumors more than 4 centimeters or node positive, and is being used in combination with platinum-based chemotherapy. Next slide. So the first trial, the 816, here it was randomization between the Nivo and CT for 1B more than 1B to 3A with no EGFR ALK mutation. It is important in all the new immunotherapy trials, they have excluded EGFR and ALK alteration. Here the neoadjuvant cycles were given for 3 cycles. Hello.
Yes, sir.
Could you please move my slides? Yeah. So if you see the endpoint, the pathological response rate, it was 24 versus 2. And the EFS, if you see the hazard ratio was 0.66. And the median EFS was 43 versus 18, suggesting it to be a positive trial and leading it to its approval. Next slide. So this is the 4-year OS data also. And here also we can see that the hazard ratio is 0.71, but the unstratified HR ratio is 0.69, and the curves are remaining separate. So it is continued to having a improved OS. Next slide. Coming to this second trial, that is the IMpower 010, where the atezolizumab was used in the adjuvant setting after receiving 4 cycles of cisplatin-based chemotherapy. Here the randomization was between atezolizumab versus best supportive care. Endpoint was stage 2, stage 3A, PDL1 TC more than 1%, and all stage 2 and 3A and ITT population. And secondary endpoint being the OS. Next slide. And here also, if you see that there was a positive benefit with the addition of atezolizumab in terms of DFS, and it was seen across the subgroup, both ITT as well as PDL1 TC more than 1%. Next slide. So the Keynote 010, the adjuvant pembrolizumab trials being similar to the previous one. Here the randomization was between pembrolizumab and placebo. Next slide. And here also, both in the overall population as well as in the PDL-T patient, more than 50%, there was a benefit with the addition of IU. Next slide. Hello. So the brief differences between the two adjuvant immunotherapy trials, the IMpower 010, which studied atezolizumab, versus the PEARLS trial, which studied the pembrolizumab. The stratification factor was gender, stage, histology, and PDL1 status, whereas in the PEARLS trial, it is stage, PDL1 status, prior adjuvant chemotherapy, and geographic location. So the key difference varies in the Keynote, the prior adjuvant chemotherapies were not for all the patients, whereas in the IMpower trial, the adjuvant chemotherapies was for all the patients. Next slide, please. And the hazard ratios were significant for both the two trials, establishing the role of adjuvant IO for these subset of patients. Next slide. So coming to the perioperative trial, the Keynote 671, herein Pembro was combined with cis plus gem or pemetrexed for up to 4 cycles and was compared with placebo plus chemotherapy, followed by surgery, and then continuation of pembrolizumab in the adjuvant setting. And here in the primary endpoint was EFS and secondary EFS and OS, and secondary endpoint was a major pathological response and PathCR. Next slide. Here also, if you see the PathCR rates, which is almost similar to the neoadjuvant trial, 18% versus 4%, and there was a median DFS benefit, a median OS benefit. Next slide, please. If you see the continued OS also, the curves remaining separate. So this suggests that yes, continuation of immunotherapy has some role, but there is still a lot to be done in this arena, like for which subset of patient is usually the adjuvant continuation of adjuvant therapy being useful. Next slide. Coming to the second trial in the perioperative setting, here in the NIVO was compared with chemotherapy, similar to the previous trial, endpoints being same like the previous one. Next slide. And here also the pathological response rate was 25% versus 4%, just being the same like we have been seeing in the previous trial, and the EFS benefit was also significant. Next slide. So AGN again did the same thing, but with durvalumab. So we'll see, and here also the endpoints were PCR and EFS. Next slide. Here also, if you see, there was a significant benefit in the PCR and as well as in the EFS. So there has been consistent improvement in the PCR rates, MPR rates, and EFS rates across the immunotherapy drugs that we have used in various trials. Next slide. So this is just a summary of all the four trials that I have talked about, with key differences like Keynote 671 included EFS and OS. Other trials only evaluated PCR or EFS. Majority included stage 2 to 3B. 3B, they have included the single station N2 disease that is considered resectable. If you see the sample size, it was pretty much good, 700, 800 odd patients, and in CheckMate there were 450 odd patients. So in general, the 4 cycles chemo plus IO regimen, surgery followed by completion of adjuvant IO for 1 year is being considered in all the perioperative trials, and across the board it has shown benefit. But OS benefit is still there, is only seen with the Pembro, and I think with the Durva study also we have got the OS benefit. Next slide. Now coming to the last section of my talk, that is the adjuvant TKI in early stage lung cancer. We know that lung cancer is nowadays usually divided as oncogene addicted, that is whether it is because of the mutations in EGFR or ALK, or if it is non-addicted. So in the previous trials, I told you they have usually excluded the EGFR or the ALK mutated patient because we have separate trials and separate drugs for this subgroup of patients. And it has seen that if we use those targeted therapies in the adjuvant setting, we know that they cause a remarkable difference when we use them in the metastatic setting. But a similar level of benefit we are now experiencing in the adjuvant setting also. It has shown reduced recurrence rates, reduced CNS relapse, and improved the survival outcomes. Next slide. So coming the first, the landmark trial that basically established the role of adjuvant osimertinib, that is the ADAURA trial. Why I said that this is a landmark, but because before this, there were other trials of adjuvant TKIs with the first generation like erlotinib, gefitinib, or afatinib, but those really didn't translate it into a good benefit. They were all apparently negative trials, but with the use of adjuvant osimertinib in stage 1B to 3A with EGFR sensitizing mutation, we have seen that there was a significant benefit in DFS and OS, and there was a markedly reduced CNS recurrence. So the treatment duration in this trial is usually 3 years of osimertinib, and the dose uses 80 milligram once a day. Safety profile is usually well tolerated and consists of fatigue, rash, diarrhea. Next slide. Coming to the ALINA trial that established the role of alectinib in the ALK positive. Herein also they have used similar stage 1B to 3A NSCLC with the ALK rearrangement, and they have used alectinib 600 milligram twice daily for 2 years, and they have compared with the platinum-based chemotherapy. A difference between ADAURA and ALINA is in ADAURA they have combined with the placebo, but here they have compared this with platinum-based chemotherapy, and primary endpoint being the DFS, and secondary endpoint being CNS, DFS, OS, and safety. And in all the endpoints, it has done well with a hazard ratio of 0.24. It's a very good hazard ratio, and 2-year DFS rates reaching up to more than 90% versus 63%. And also the CNS DFS was good with the 2 years of alectinib post surgery. So based on this trial, FDA has approved alectinib as standard in ALK positive resected lung cancer. Next slide. So this is a Me Too drug, just like osimertinib. We have this another drug called aumolertinib, which is basically approved in China based on the ARCH trial. It's a phase 3 trial, and herein they have they have included completely resected stage 1B to 3A EGFR mutant lung cancer, exon 19 L858R, and aumolertinib was compared with platinum-based chemotherapy here. Duration is similar to 2 to 3 years, and herein there was a significant DFS improvement with aumolertinib, and there was marked reduction in CNS sickness like we have seen in the osimertinib trial. Toxicity profile, again, as reported, is considered to be generally well tolerated with rash, diarrhea, and low rare cases of ILDs. But there was a lower hematological toxicity compared to the chemotherapy arm. So this again confirmed the third generation EGFR TKI superiority over chemotherapy in adjuvant setting, and supports EGFR TKI based adjuvant therapy. Next slide. So there was another trial called the NEO-ADAURA trial, in which they have used neoadjuvant osimertinib plus minus chemotherapy in the resectable EGFR mutated NSCLC. It's a phase 3 design in which they have included the resectable stage 2, 3B, and 2 EGFR mutant NSCLC. The arms here in the osimertinib alone, osimertinib plus chemotherapy, and chemotherapy alone. Treatment duration is 9 weeks. Primary endpoint is the MPR. Secondary endpoint being EFS, PAS-CR. And up till now, that we have the interim results, it has shown a higher MPR with pathological CR with osimertinib containing arms. So osimertinib alone is, or osimertinib plus chemotherapy, both are doing well, and there is not a very significant difference between the two, at least what we can see with this interim results that we have till now. It has a high R0 resection rates, and there is better tolerability compared to chemo alone, and improved nodal downstaging also. So it is basically faring on all the endpoints. The rationale here is a neoadjuvant leads to rapid tumor increase, higher CNS penetration, potential eradication of micrometastatic disease with acceptable toxicity profile. Next slide. So this is just the comparison of the 3 trials, ADAURA, ARCH, and the NEO-ADAURA. NEO-ADAURA is for the neoadjuvant, ADAURA and ARCH are for the adjuvant. And what I can say is we are having a consistent results with the third generation EGFR TKI, both in the neoadjuvant as well as the adjuvant setting. However, the neoadjuvant osimertinib is still yet not approved. Next slide. Thank you.
So after an excellent opening inning by Dr. Satya for us, I would like to move on to our next session, that is on the what's new in the lung cancer. Are my slides visible?
Yes, sir.
Okay, so we will start right up on the topic that what's new in the lung cancer, and we will discuss about all the updates in the ESCO, ESMO, and the LCC of the last year, and be ready for the this year updates. So we will start right upon from the SCLC, that's a small cell lung cancer, and as we know that in the SCLC, the first line standard of the care is the use of ICI along with the first line of the chemotherapy, that is on the basis of IMpower133 and the Caspian trial. We have used Atizo and durvalumab, and only for the 4 cycles along with the chemotherapy. But we don't know what to be done after that, because most of these patients progresses. The earlier trials which has been done on this setting, including the Checkmate 451 trial, has failed. On the basis of that, this trial was kept forward. That is a IMpower trial where we have used lurbinectedin and atezolizumab combination in maintenance phase. In maintenance, the lurbinectedin is used in the dose of 3.2 milligram per meter square, along with the atezolizumab. And in the patient who have already responded to the induction phases. And the primary endpoints was progression-free survival and overall survival. And as we can see here, the progression-free survival as well as the overall survival has responded very well. The progression-free survival hazard ratio is excellent, 0.54, and a median progression-free survival is gained of around 5.4 months in the comparator in the study arm versus 2.1 months in the comparator arm. In the overall survival as well, on the right side, we can see the stratified hazard ratio is in terms of 0.73. As per, if you look at the subgroup analysis, we find that almost all the subgroup have responded well. And interestingly, all the patients who had a liver met as presentation had responded even better. Those of the patient who had no PCI have responded well as well. Similar to the story in the case of OS as well. And if you look at the overall response rate, we find that with the use of the study arm, the ORR received is in the range of 19.4 percentage point. If you look at the safety summary, we find that, of course, with the addition of lurbinectedin, there is an increase in the side effect profile, but this is mostly in the terms of sepsis and febrile neutropenia. So probably moving forward, IM4 trial has established lurbinectedin and atezolizumab as probably an SOC, which must be reflected in the upcoming in the guidelines as well. Now, moving to our second trial, that is the ECLIPSE trial. Here we have used atezolizumab in the limited state SCLC. And as we know, in the LS SCLC, we have only one trial which is positive in the terms of IO, that is ADRIATIC trial, where we have used durvalumab as a consolidation after the use of RT. Other trials have already failed. The atezolizumab trial had already failed, which was LU005 trial, but probably AstraZeneca thought that why not to add atezolizumab along with the RT, along with in the consolidation only, as was there in the ADRIATIC trial. So on this basis, they started ECLIPSE trial, in which atezolizumab was added only in the consolidation phase, and no addition of atezolizumab was done along with the RT. But unfortunately for us and for them as well, it has failed. The primary endpoint was a 2-year OS, which has failed. The hazard ratio is around 1.14. So as of now, in the LS SCLC, probably we have only the presence of ADRIATIC only. So now we move to all the Delphi trials, which have an interesting drug. We have variety of trials, which is Delphi 305, 304, and 306. Here we will read about Delphi 304, but we have other interesting trial as well. Delphi 305 looks at use of maintenance of tarlatamab along with durvalumab, and it is on the lines of IM4 trial. Its result is still not out, and there another trial is 306, which is on the line of ADRIATIC trial, which looks in the LS SCLC stage, and the use of tarlatamab as a consolidation. Now here we have Delphi 304, which is use of tarlatamab in the advanced and refractory setting of SCLC. And if you look at the regimen use, it is day 1, 8, and 15, then followed by every 4-weekly regimen, which is mostly a regimen which is used probably in the fulvestrant type. The primary endpoint here is overall survival, and the results are out. It was presented in the ESCO last year. As you can see here, the response is probably excellent with the use of tarlatamab. The overall survival has has around doubled, with a stratified hazard ratio for death is around 0.60, with the overall response rate of around 35 percentage point. And then at the safety summary, all the safety summary is almost equivalent except the terms of CRS. The CRS in the tarlatamab arm is in the range of 56%, which is one thing that we have to keep in mind. Another trial of the Delphi subset is Delphi 303, where we have used maintenance again with the tarlatamab. The difference between other trials here is that it has used tarlatamab along with both of the immunotherapy which is approved, that is along with the atezolizumab as well as with the durvalumab. Atezolizumab is used in the 4-weekly regimen, while the durvalumab is also used in the 4-weekly regimen here. If you look at the response rate, the overall survival is not matured, but if you look at the median progression-free survival, probably it is similar, 5.6 versus 5.3, and probably atezolizumab has a slightly upper hand here. And if you look at the response rate is also fine, not best. This is around 36% of the patient had a disease control. In the SCLC, probably it works well. And if you look at the investigator conclusion, we find that overall response rate 24% and a DCR of 60% is actually good. And but we have to look forward to his CRS and ICANS. And as per the investigator, these ICANS and CRS was also primarily grade 1 and 2, and all were resolved. Next, we have to jump into our again subset of NSCLC, and we will start with a neoadjuvant phase. In the neoadjuvant, we have the first trial, that is El Neo trial, which is the use of alectinib in a neoadjuvant phase, where we have used neoadjuvant alectinib 600 mg BID for around 2 cycles. 1 cycle means 4 weeks. So we have used around 8 weeks of alectinib before surgery, and which is followed by surgery within a month, and followed by an adjuvant phase of alectinib 600 mg for up to 24 cycles. The primary endpoint is major pathological response, and it has an interesting design of Simon stage 2 minimax, and where the null hypothesis is rejected only if the MPR has the number of 11 or more. And fortunately for us, the MPR is in the range of 14, and 4 patients has also received major pathological response as well, which is interesting because if we consider the fact that lorlatinib has not still been used in a neoadjuvant setting, so probably with the use of a lorlatinib, probably we will in the future achieve a more higher responses rate as well. But right now, the El Neo trial, the response rate is also good, and MPR is good. The overall response rate is also in the range of is higher, around 48% experience a downstaging at some point, and most of the surgery done here is a lobectomy, then a pneumonectomy. If you look at the safety summary, most of these were well tolerated. There were, of course, side effects, but they were mostly mild and well tolerated. Next trial, which was already discussed by Dr. Satya, is a new ADAURA trial. I'd just like to point out the difference between this trial versus the El Neo trial. In this trial, we have one arm of osimertinib which has combined with the chemotherapy as well, and this arm has not performed well. In fact, this is osimertinib monotherapy arm which has performed excellently. In the terms of MPR, it is same, and in the terms of EFS, it is a better arm. And in the terms of safety summary, obviously, osimertinib single agent is, of course, a better therapy than an osimertinib along with the chemotherapy arm. Now, we again move to our new adjuvant trial, again, CheckMate 816, which was presented in ESCO. And this is a highly awaited trial because the secondary endpoint is in the terms of overall survival, which was presented in ESCO last year. And we find that CheckMate 816 had a consistent overall survival benefit, and hazard ratio for death in the terms of OS is 0.72. And it was consistent across all the subgroups. And hazard ratio is also there in the stage 1B to 2, and as well as stage 3A. And the overall survival is, as we have talked about, is across all the subgroups. It is more in the patient who have a TPS of 1 or more, but it's also thus there in the TPS is less than 1. Our next trial is a SOHO 01 trial, which is an interesting drug. Cevabertinib is an oral anti-HER2 drug, and this is a trial which is a phase 1 and 2 trial of using cevabertinib. First is a dose escalation, and which is followed by expansion and extension. The earlier dose, which is the dose which is fit for expansion and extension, is the 20 mg dose, and it is further divided into 3 subsets. The middle one, that is the E subset, is the one in which the patient had already been exposed to anti-HER2 earlier. So we have to look in that subset the response rate. The primary endpoint is in the terms of ORR, and while there are various other secondary endpoints. So if we look at the baseline, we find that the activating mutations and HER2 domain mutations are the 2 other subgroups that are pre-specified. Activating HER2 mutations include all the mutations, including the HER2 point mutations. So if we look at the response rate, we find that the response efficacy is high. The ORR is excellent, it's 70%, and MPS is in the range of 9.6 months. But interestingly enough, we find that in the subset of the patient who had an HER2 domain mutation, the response is slightly less than in the terms of HER2 other mutations. So probably in the future, we will do these HER2 sub mutations as well. And as per the investigator conclusion, we are now moving towards a phase 3 trial, that is a SOHO 02 trial, and probably which will evaluate this drug further. Now we have another trial, that is a SACHI trial, and it's one of the important trial in the presented last year. We have SACHI trial, which was presented in the ESCO, and we have SAVANNAH trial as well, which was presented in the ESMO. So we will just discuss this trial, that is savolitinib plus osimertinib in the patient who are EGFR mutated and has already been exposed to an EGFR TKI, and on progression they are also MET amplified. In those patients, the savolitinib 600 mg is combined with osimertinib, and in comparator arm we have platinum-based CT, which is followed by a PEM maintenance as well. The primary endpoint here is progression-free survival, and if you look at the progression-free survival, we find the hazard ratio is so excellent. All the hazard ratio is in the terms of 0.3 or 4 across all the subgroups, whether we have used a prior osimertinib, whether we have used a prior first generation or a second generation, we have the patient without brain mets or with brain mets. There is an excellent response with the use of this Savo plus osimertinib regimen. And if we look at the response rate, again, we find that Savo plus osimertinib response is in the terms of 58% ORR, while a disease control rate is in terms of 89%, so which is excellent. And so probably this drug is there to stay for us in the future and will be reflected into the future guidelines as well. Then we have another drug, that is the HERTHENA lung 02 trial, and we have HER3-DX, which is used in the terms of 5.6 mg per kg every 3 weekly for all the patients who have been exposed to an EGFR TKI 1 or 2 line. And the primary endpoint was progression-free survival, and we find out that it has responded probably slightly less than what is expected in the terms of numerical advantage. The advantage is very less, but in the hazard ratio, it is still okay in the terms of 0.77. The median OS is not yet mature, but it is probably not on the lines of improvement. The hazard ratio at right now is in the terms of 0.98. So another drug which is in the study is Dato-DX. Dato-DX is being studied in the ORCHID modules, which is a platform study, phase 2 platform study. And here in the ELCC last year, an ORCHID module 10 was discussed. And in this, we have Dato-DX. 2 doses are there along with osimertinib. One is a 4 mg dose and second is a 6 mg dose, and the primary endpoint is ORR. As we can see here, this is a background, so Dato-DXd is a TROP2 ADC, we all know, and it has been already evaluated in the TROPION-Lung 01 and 05 trial, and it has got a breakthrough definition and priority review status by the FDA. Now, as we look in the overall response rate, we find that the response rate with the 4 mg dose is slightly higher, but in the terms of progression-free survival, the 6 mg dose wins because the progression-free survival with the dose of 6 mg is around 11.7 versus 9.5. So as per the investigator have concluded that 6 mg Dato-DXd is a preferred initial dose to be used in combination with osimertinib, and probably in the future trials, the TROPION-Lung 14 and 15, this is the dose we are moving forward. Our next trial is TROPION-Lung 02, which has again used Dato-DXd. Dato-DXd here is used in the patient who have no actionable mutations right now, and they have divided into variety of subgroups. One of the subgroups are having a doublet, that is a Dato-DXd along with the pembrolizumab, while in the other subsets we have this combination along with the carboplatin as well. So a doublet and as well as a triplet. So let's find out that which has performed better. So surprisingly enough, a doublet has performed better, and the ORR in the cases of a doublet is 54.8, while in the triplet is almost similar. The progression-free survival in doublet is 11.2 versus a triplet which is 6.8, and a median OS has not yet reached. And again, this is the same thing. The patient who have a PD-L1 of more than 50% have responded excellently. Again, the overall response rate is 100 with the use of doublet. Our next trial is a MARIPOSA trial. We already know about this trial. Amivantamab and osimertinib is compared in this trial, and the OS benefit is there. This final OS benefit nails this MARIPOSA regimen as a first-line SOC in the patient with a EGFR mutated NSCLC. So it has a benefit across all the subgroup as well. So investigator do conclude rightly that probably this is a first-line SOC. So we have these two trials, the MARIPOSA trial and FLAURA2 trial, which have established the SOC for the first-line NSCLC right now. And then we have some drug that is zipalertinib. Zipalertinib is a drug which is available for the patient who have progressed on exon 20 insertions. And as we would know that for exon 20 insertions, we have amivantamab right now. So those patients who have probably progressed on amivantamab, or those who have been progressed on the chemotherapy alone, we have this drug zipalertinib in the dose of 100 mg, and RESILIENT-1 is a trial which has studied it. The response rate is good, but the patient who has already been exposed to the amivantamab, the response rate has been lesser as expected. And progression-free survival is also in the terms of 9.4 months, and those who have received amivantamab earlier, it is in the range of 7.3. So probably this drug will be, we will seeing this drug, and we have another option for the patient who have progressed on amivantamab in the future. And then we have HARMONi-6 trial, which is an excellent design trial. We have this drug ivonescimab, which is very interesting that it is a bispecific drug, and it has one end of PD-1, anti-PD-1, and another end is anti-VEGF. So this is one of the drugs which is a newcomer, and variety of HARMONi trials has been done. This trial specifically is done for the patient who are squamous NSCLC stage 3B to 4, and the comparator arm is also strong. Tislelizumab has already shown us to be an important and a strong comparator arm. So the primary endpoint here in this HARMONi-6 trial was progression-free survival, and it has responded excellently in the terms of progression-free survival. So it has, so we have always believed that in the squamous NSCLC, anti-VEGF will not work, but probably by this trial, we have proved that anti-VEGF may work in the terms of ivonescimab. And then our few honorable mention for the ESMO is one of the trial is OptiTrop Lung 04 trial, which has used SAC TMT, which has responded very well. Then we have a Bimion Lung 1 trial, which has used jongatinib, which is also an interesting drug. And then we have Savannah trial. Of course, we have Saffron trial as well, and which we have discussed earlier. So finally, concluding is that this is because has been a marathon run. So my take-home message is that in neoadjuvant setting, a neoadjuvant and El Neo trial are good. Thumbs up to them. In the first line metastatic setting, FLAURA2 has been good. Olomortinib has been probably bad, not as good. Mariposa is definitely a challenger to a FLAURA2 and probably a new SOC along with the FLAURA2 as well. In the osimertinib progression, we have to look for a biomarker. We have to look for MET, HER2, and retained EGFR as well. And one of the options is to go for, again, a chemotherapy. If it is, we have other options as well. We have the option to go for SAC TMT. We have the option to go for a Dato-DX, but probably a Dato-DX has only a small amount of benefit. Then we have the option to go for a Mariposa 2. And finally, we have the option to go for, if there is no MET, SAC TMT again. And HER3 DX has been bad. And if you look at the MET amplified, then this is very good. Savolitinib plus osimertinib, as proven in all the trials, including the SACHI 3 and Savannah trial, has been good. If it is a HER2 mutant, probably in the future we will have a new drug, jongatinib. And if you look at the other trials, the Mariposa 2 PFS benefit is there. The final trial, this ivonescimab, which is probably good and coming in our future as well. Thank you.
Thank you, sir.
So I think as we are short on our time, we can start off our next session with Dr. Animesh, as will lead us towards a extinguished panel discussion. And I give my this stage to him.
So as we move on to our first panel discussion, I would like to invite Dr. Animesh Agarwal, sir, for moderating the session. Joining him, Dr. Santosh Reddy, sir, Dr. Manas Dubey, Dr. Saksham Singh, and Dr. Shamila Alim. Unfortunately, we couldn't have Dr. Saksham Singh with us. So I would like to hand over the session to Dr. Abhishek, sir. Sir, over to you, please.
Abhishek, so with your leave, maybe we can begin.
Of course,
I will
sir,
just,
please.
so I'll just share my slides. So they should be visible. So the topic that I was provided was a discussion on oligometastatic lung cancer. That is a very broad diktat. So I decided to stick to oligometastatic NSCLC. And the second disclaimer, even that I found to be too broad a diktat to try and cover within 30 minutes. So and not lose track of the plot entirely, So I have tried to keep it focused on the questions that we typically encounter in our practice. And let's see where that takes us. In my panel, I have Dr. Santosh. I believe I saw him here. Dr. Santosh, are you here?
Yes, sir, I'm there here. I'm there.
Yeah, great. So Dr. Santosh is a medical oncologist at Omega Hospitals in Karimnagar. Dr. Manas is also here. Dr. Manas Dubey. He's a consultant medical.
Okay.
Yeah, great to have you, Manas. So he's a medical oncologist at Prayagraj, Kamla Nehru Hospital. Dr. Saksham, a dear friend and colleague, but it seems like we do not have him today for this discussion. But we do have a radiation oncologist, Dr. Shamila, who is
Hello.
practicing. Good evening, doctor.
Good evening.
So you're practicing at BB Poddar in Gorakhpur, right?
Yes.
Yeah. So great to have you. Oligometastatic NSCLC. Obviously, we need our colleagues for local therapy. I mean, maybe a surgeon would have been rounding off the complete thing, but I think we can work with what we have. That's we have a complete panel of oncologists for this. Briefly, we'll try to talk about what exactly is oligometastatic disease, what are the factors affecting our choice for therapy for these patients, what do we do for re-biopsies, liquid biopsies. I mean, we are all conversant with these phrases, and one illustrative case that will try to weave through this entire discussion. So what is oligometastatic disease, right? So, Dr. Sharmila, so what do you say? What do you like? How do you classify a disease to be oligometastatic?
Okay, for oligometastatic disease, I think there should be less than 5, or the best thing is 1 to 3 metastatic lesions. And the main purpose of going from radical to palliative, this is the mid thing, oligometastatic, the new concept for the patient to be treated radically and cure is possible. Location of metastasis, talking about lungs, it's mostly brain, adrenal, local recurrence. So mostly we see metastasis here.
Right, right. So, Dr. Santosh, anything to add in terms of number of organs that may be involved? So,
Yes, sir.
anything
It has to be like there are number of concepts actually, like how many number of metastasis. It's a bit of like hazy area. Somebody says less than 3, somebody says less than 5. But if you talk about the number of organs, it has to be less than 3 organs per se. But if you talk about location of metastasis, mostly it's brain, adrenal, as well as opposite lung, as well as
Okay.
liver.
Okay. Fair point. So, Dr. Manas, would you have anything to add to this? I mean, or any thoughts on this?
So I agree with the panelists. So I think the number of, as per ESMO, they include around up to 3, and NCCN 3 to 5, and URTC up to 5 metastases in up to 3 organs. And
Yeah.
IACLC also included this up to 5 metastases in up to 3 organs. So I agree with the panelists. So these should be, I think, included in the definition of the oligometastatic NSCLC.
Right, and of course, and who am I to disagree with my esteemed panelist colleagues? So, I mean, this is just what Dr. Manas just mentioned. So the ISRO guidelines, they also recommend something similar, and essentially up to 5 organs and up to 5 or discrete metastases and up to 3 organ systems, right? And the organ systems could differ, and of course, depending on that, we manage our patients. However, one important thing that all guidelines seem to agree upon is that diffuse serosal metastasis, so the peritoneal metastasis, let's say leptomeningeal disease, that sort of thing, or bone marrow involvement excludes cases from the definition of oligometastatic disease, because that then makes it very difficult for us to treat our patients locally in these cases. So what factors would influence your treatment decisions for these patients? So Dr. Sharmila, let's take these one by one. So synchronous versus metachronous meds, what's your take on that?
Mostly in the trials and all, it has been seen that metachronous, the diseases which are metachronous, they perform better. The overall survival and PFS is also better. And regarding the disease burden, it is in terms, I think, of oligometastatic only. The lesser the burden, the better is the treatment. And talking about radiation, I think medical oncologists will give more light on the disease burden, because we only treat the patient who have local recurrence, or which are due for radical treatment like SBRT. So I think disease burden should be discussed first with medical oncologist.
Right. So disease burden आपको कब मिलेगा तभी तो आपको बुलाएंगे. Right. Heavy disease burden के साथ it's always tough for local therapy. Dr. Santosh, so what's your take on the DFS, PFS? Like, what's your take on that?
Okay, first of all, if you talk about oligometastatic disease per se in the lung, there are no standard clear-cut guidelines like what to do the first, whether the patient will respond or the patient won't respond, whether local regional therapy is needed upfront or after the systemic therapy. There is some kind of confusion always in oligometastatic disease. If you talk about the synchronous versus metachronous, there are a number of different scenarios. If the patients, for suppose, if you talk about driver alteration, If the patient is upfront having EGFR or all alterations as well as synchronous, we won't touch the synchronous because as we know, EGFR and all they respond exceptionally well with the tyrosine kinase inhibitor. So at that point of time, if you talk about synchronous, we won't touch. And if the patient is having oligo progression, at that point of time, we will do the local regional therapy. Whereas if the patient is having, suppose if the patient is having brain mets and the EGFR and ALK is been negative and all the drivers are being negative, the patient is symptomatic for that. At the upfront setting, we will touch the brain and we will have the SBRT or some kind of local therapy, whichever is possible for the brain, and then we will treat the systemic disease. It depends upon the case by case basis. It's not like if the patient is having heavy disease burden per se, the main thing is we have to address the systemic therapy. First, systemic therapy has to be given and then followed by any local regional therapy based upon the patient performance status.
Right, absolutely. It's like you highlighted. It's a nightmare. The sheer number of permutations that is possible, the ways, the myriad ways the patients can present to us, and it's given that nearly all these patients are presented with metastatic disease. I think we've pretty much all seen everything. I mean, yeah,
Right. Like
So
my online mentor is Angel Digelman. So she's one of the stalwart in lung. So she's my online mentor, and recently only I had a talk with her. So based upon the oligometastatic, like one of my patient has oligometastatic with brain mets, but EGFR was negative and the patient was asymptomatic. So I thought first at the first point of time I thought to address the brain and then go for the systemic therapy. But she was telling until and unless the patient is symptomatic for the brain, you don't touch the brain. You go ahead with the systemic therapy and then followed by if the patient is having any kind of symptom, then only you go for the local therapy for the brain.
Yeah, all kinds of schools of thought, right? Every patient throws up new challenges.
Correct,
Dr. Manas.
So similarly, I will
yeah.
discuss within one of my also case scenarios. So this is one of my our institute CA's father. So what happened? He presented with CA lung squamous cell carcinoma, primary stage 3B. So we did an MRI. MRI with, around is less than 5 mm focus. So two radiologists say it is metastasis, and another said it is not likely, too small to define it. What is the disease? So and the primary size was too large, so we decided in tumor board that we will, and the NGS panel was MET exon 14 skipping positive, PDL1 was more than 90%.
Yeah, that's
okay. So we started with we will go with the Pacific so we started with because radiation oncologists were saying that the field was too large, so it might be will be difficult to encompass in the field. So we started with NSCT. So after giving two cycles of paclitaxel, patient is 75-year-old. So excellent response to primary, but what happened on the brain lesion, left frontal, we had a metastatic site. Okay, so now we started on tepotinib, and after 3 months again, the size was slightly increased, and tepotinib is very costly. We know that after 3 months, so they said that it is increasing, so we want to change. So now we have started on the chemotherapy with the immunotherapy because of the PDL1 is more than 90%. So patient is on follow-up now. So around 8 months, this case is going on right now. So this is how we are dealing in our real practice. Okay.
So what does the data tell us as far as these prognostic factors concerned? I mean, obviously we have all touched upon this, but just a small brief look at what the data is there. So this is the largest data set that I could find for patients with oligometastatic NSCLC, around 750 odd patients, median age of 60 years. However, the number of metastatic lesions was very, very less. So around 88% patients had only just a single metastatic lesion, and around 8% had only 2 lesions. So 96% of patients had 1 or 2 lesions only. But and 80% of these patients underwent surgery of the primary lesion. So I mean, that is a huge number. 80% primary disease getting resected. I think it is unthinkable in our clinical settings.
Correct.
But I mean, for what it's worth, this is the number that I could find. But with this patient profile, they reported some excellent numbers, right? So 2-year OS of 50%, 3-year OS of nearly 30%. So they found some really good numbers. But of course, with this kind of patient profile, there was going to be good numbers. what was interesting was the prognosis for various subgroups of these patients. And when they did the multivariate analysis for these patients, patients who had non-surgical management of primary disease, patients with lung metastasis, brain metastasis. I mean, brain metastasis obviously is a no-brainer. Multiple organ involvement. So if it is a single organ involvement, it turns out it is better. Again, something that we intuitively seem to know. The higher the number of metastasis and a poor response to systemic therapy, these are all factors that portended towards a poor response and a poor survival. Again, so these are all factors that we intuitively understand to be affecting the outcomes of our patients. And accordingly, we of course do select these. I mean, I guess we do this more almost at a spinal level these days. I don't think there is any formal scoring available, and as Dr. Santosh mentioned, there is no real rule. This is what you find. If you find A, you do B. That's not how it is in the clinic. So similar data for some. So this was for non-oncogene addicted. And for oncogene addicted tumors, so there was a study out of China, and the numbers were similarly quite striking. PFS 20 versus 12 months for patients who receive only systemic therapy, were 12 months, and for patients who receive systemic therapy plus local RT to the disease and metastatic sites, the PFS is markedly improved, and so was the overall survival. So again, so this is and then of course we also have the data from the SABRE comet, the other very famed data for oligometastatic cancers. Now only a very small number of patients with the NSCLC, so only around 15 to 20 patients with lung cancer in the SABRE comet, and on the long-term results, for what it is worth, the median PFS and OS were significantly better for patients who received SABRE or SBRT, as we like to call it more commonly, to all of the eligible metastatic lesions, and these patients were doing better. Again, we do not have the subgroup data for specifically patients with lung cancer, but at least broadly speaking, we see that the patients who get treated for oligometastatic disease do seem to do better. So coming briefly to the case then, I mean, this is just an illustrative case, not a real case. So a 56 male non-smoker, we find presents with cough, shortness of breath, biopsy shows an adeno-CA, and EGFR sensitizing mutation, common mutation L858R, and along with the TP53 mutation that has been detected on the NGS, PD-L1 CPS is 12%. I mean, fairly common scenario. We find these patients often enough. The disease is metastatic, and the lesions are one in the L1, one in left adrenal, and another in liver segment 4B. So we have the clinical scenario. Dr. Shamila, what would you like to do?
For this, I think this is qualified as oligometastatic since only 3 metastases is there. Depending on if there's one lytic lesion in L1, we can go for RT, of course, if the patient is painful. And along with this, I think systemic therapy should also be started, or immunotherapy, as medical oncologists will suggest. But definitely RT has a role in this.
Right. So Dr. Santosh, agree with Dr. Shamila? Any disagreements? What systemic therapy is your plan?
Yes, I agree with Dr. Shamila, but it depends. Like if you see, like in our case, it's an oligometastatic disease, like lung cancer with an EGFR mutation is there, L858R. We can target that one with a third generation tyrosine kinase inhibitor, right? So upfront, there is no need to touch any local therapy. If at all patient is asymptomatic, I won't touch any local any RT the patient is needed or not. I am not sure whether the patient is symptomatic for that or not. But if you talk for say, if the patient is asymptomatic and has with a good performance status, definitely I would go with an EGFR L858R target therapy like fostamatinib plus chemotherapy.
Right. Okay. Plus chemotherapy.
Right.
So, Dr. Manas, you agree with Flora 2, or you want to stick to Flora? What's your approach? Chemo added or
So
not?
I think TP53 mutated, so I think they perform slightly worse than the single exon 21. So we will, I will like to add the chemotherapy along with the osimertinib. So
as well as if you see that the patient is having the liver mets, right? These patients will be doing worse when compared to the brain mets or something like opposite lung mets or bone met. So better to add chemotherapy upfront if the patient is having liver mets.
But
Absolutely.
I think there are few medical oncologists also. They will start with the single agent TKI maybe. But I think because of TP53, So,
Yeah,
so
yeah,
Animesh,
I
what
think
will you do?
Yeah, नहीं, अरे भाई आप लोग हो, I am not disagreeing with two medical oncologists on my panel, भाई. I am absolutely in agreement with the P53 in there. I am sticking to chemo plus osimertinib, FLAURA2 all the way. And this hypothetical case also had a hypothetical progression after 4 cycles of chemo osimertinib, FLAURA2. He has had a very good response in his primary adrenal and L1. Let's just, I mean, regardless of the L1 lytic lesion being symptomatic or not. I mean, if it is symptomatic, it has received palliative radiation. If it is not asymptomatic, again, agreed, we can simply observe and keep him on bone modifying agents and continue with the systemic therapy. But regardless of that, patient was continued on systemic therapy, 4 cycles of chemo osimertinib. Primary adrenal and N1 lesions have all improved significantly, but the liver lesion has now doubled in size. So, well, now, Dr. Shamila.
Okay, so now if the liver lesion has doubled and it has failed systemic therapy, I think now the role of SBRT may come. Patient may be given local treatment, and this is a stereotactic, it is an ablative technique, non-invasive ablative technique. So we can go for SBRT for liver, and it has seen that in long term, it increases the progression-free survival, further increasing the overall survival. So maybe 16, 3, 15, 5, whatever the doses factors in the institution, we can go for SBRT liver.
Right. So sounds like a logical plan. So Dr. Santosh, anything, would you like to do a biopsy at this stage? You are just okay with let's get the radiation on and continue systemic therapy. What's your take?
Like if the liver size has been doubled and the patient is symptomatic for that, so definitely I want to have a repeat biopsy. So I want to
Okay.
check whether the EGFR LH58R is retained or any kind of MET amplification. We have got something because of already we have used osimertinib upfront. And yeah, there are now we'll be discussing this case in MDT, and we'll have the opinion of surgeon as well as the radiation people. So it's their call now whether the surgeon has to operate upfront or whether the RT people have to go for the SABR.
So Dr. Santosh, we are in an MDT, no? So Dr. Manas, we are in this MDT, right? We have
Yes,
a
yes.
nice
So,
MDT
so
here,
I agree with
radiation
the
oncologist.
okay. So I agree with the radiation oncologist, but we have to see the size for the
SBRT.
for
Suitability for
size to
right.
be included in the SBRT. But
Yes.
still, if patient is asymptomatic and there is no LFT derangement, so I will continue now with osimertinib for 2 more cycles, and then I will again repeat, because we have seen in clinical practice sometimes response comes late, or the
Fair
region
enough.
becomes stable or a region. So I will not go at this point.
Okay.
Biopsy is an option,
So
but still I
so
will.
if the lesion is so you are giving us an alternative. Fair enough. We can consider a pause on
Suppose 1
let's just take
centimeter
a step
lesion
back.
become 2 centimeter, so it is also doubling. But
Yeah,
again,
of
yes.
course.
So
तो ये
then
2 का 4 मतलब 1 2 का 4 है या 0.5 का 1 है, that sort of
yes,
thing. As
that is
long as
also we have to see.
yeah, look at the absolute size. Absolutely. Again, something that's a very, very, very valid point.
Yes, of
Right.
course, I agree.
So before we move on with this case, another question that I found very interesting. Role of consolidative RT to primary, right? We are all talking about the local therapy to the oligometastatic disease sites, right? So for in this particular case, you're talking about the liver, the adrenal, and possibly the L1, right? So what about the consolidative RT to the primary lesion? So while there was a lot of preclinical, sorry, let's not say preclinical, but a lot of retrospective anecdotal data regarding the same. I found one phase 3 study. It has been reported in ASCO in 24, presented there. The manuscript I still could not find, but I did find a presentation by the primary author, the first author, Dr. Puneet. And this was the study. It's a fairly simple trial design. Patients with oligometastatic NSCLC at presentation, these patients were receiving 4 cycles of first-line induction systemic therapy, so pemetrexed platinum. And so for squamous patients receive a taxane platinum typically. And these patients, after a response had been achieved, were randomized to receive either maintenance systemic therapy only or SBRT to all sites of metastasis plus irradiation of the primary site as well, along with maintenance systemic therapy. And in this trial, one of the major criticisms of prior studies was always that all patients did not receive standard of care, right? So this trial enrolled patients with no driver mutations, and 90% of patients on this trial received immunotherapy in both arms. So patients have all received immunotherapy. There are no driver mutations, and patients have had a response. They were randomized to continuing IO and pemetrexed or whatever. And patients are obviously also getting radiation in the control in the experimental arm. So, right, as mentioned, 90% patients in both arms receiving immunotherapy, and around 85% patients had only 1 or 2 lesions, the remaining 15% patients having 3 lesions. And the results, quite frankly, disappointing. The addition of the local RT did not improve anything in terms of either PFS or OS. So, both PFS and OS curves look very, very unimpressive, overlapping, pretty much swapping all the time, crisscrossing each other's. So not a very good looking OS curve or PFS curve. I mean, this data aside, do you consider local consolidative RT for patients who have received systemic therapy and shown a response? I mean, for instance, if this case that we were discussing, if the liver lesion had also responded, Dr. Shamila?
This is, I think, trials show that this is not practically possible, and consolidated treatment for patient after systemic therapy, I think there's very less number of people who will be coming at this stage. But still, I think it is will be a tumor board discussion, and the treatment will be decided based on that only. In my small clinical experience, I have not seen such a case where I have given local consolidated treatment after systemic therapy. Maybe role of SBRT is always there, but consolidated treatment maybe very few cases.
Dr. Santosh, any difference?
No, I agree with Dr. Shimila that if you see, like in our case, if you see the patient has responded to bone meds, liver meds, adrenal meds, completely washed out, and there is only the small lesion primary. So I would like to offer a radical intent of treatment for this kind of patient, but I have never tried it.
Theoretically.
Yeah, I think Dr. Shamila, I also have the same thought here. Dr. Manas, would you have any disagreement here?
So if patient is driver mutation positive, then definitely I will not add the local consolidative therapy. Also, if patient is had received immunotherapy and still on maintenance immunotherapy, I will still not add local consolidative therapy. But yes, if patient has none of received, these only received chemo and responded good, partial response or CR, then I will add the consolidated therapy to the primary.
Lovely response. Actually, I really like your answer. I mean, very well structured. 3 points of consideration. I like to summarize. I really like this particular answer. So if there is a driver mutation, we have had a very good response. I doubt any of us is considering this patient for consolidative therapy. Patient has responded well. It's a driver responsive tumor, and we will most likely continue to respond for a while. If it is a driver negative tumor, if it has received immunotherapy, then the risk of pneumonitis probably outweighs the potential benefits of radiation. And
Correct.
in fact, in this trial, one of the reasons supposedly for no
Because
benefit
immunogenicity, correct.
was the fact that there was a lot of pneumonitis.
Yes.
So definitely. And for patients who are not receiving immunotherapy, don't have a driver mutation either. Now, this is a patient who will probably not have a long response, right? Chemo will fail sooner rather than later. And there is no immunotherapy to do the heavy pulling, those long responders who will jinki immuno chali ja rahi hai. So we do not, these are not those patients, and definitely local consolidated therapy can be an attractive option for these patients.
Correct. This is my point.
Yeah. So rebiopsy, I mean, we stopped at that particular patient, in this particular patient, where the liver metastasis has increased in size, right? And Dr. Santosh mentioned that he could consider a repeat biopsy at this point. Dr. Shamila mentioned that we could go ahead with radiation, both valid choices. And Dr. Manas offered the possibility that maybe we give it a bit of a break. Maybe we continue therapy for 2 more cycles and wait and watch what the lesion does. But the question that I had was, why would we do repeat biopsies, or why would we consider liquid biopsies? I am not going into the depths of how these things are done. We are all assuming we are adults here. We have been doing this for a while. We know what these things are, right? So, Dr. Santosh, your take. Why would you do these things? Why would you do it?
First of all, like in our patient, like per se, if we see the patient has received osimertinib, so if the patient is on osimertinib and having the disease progression, first of all, I would like to check whether there is any kind of loss of that mutation, or whether any new mutation has popped up, like exon 14 skipping mutations. or any like histological transformation if it has been done. So I want to check for that so that my management will be changing based upon that.
Right, right. So, Dr. Manas, ever encounter a loss of a mutation that you had previously found in an NGS? So, पहले EGFR मिला and बाद में जब करा तो पता चला there is no more EGFR. Has that ever happened to you?
No, I've never found like that. Maybe some new mutations are there. Yes, we have found on
Okay.
tissue biopsy also, as well as on the Foundation 360. So maybe liquid biopsy. But I found newer mutation that is maybe relevant or non-relevant, but not as found like this.
Okay, so this happened to me actually with once when what happened was the patient NSCLC adeno EGFR progression and by rebiopsy on a new lesion came out to be small cell, right? And the small cell, I mean, out of hope more than anything else, I did send for NGS, and this time I didn't find any mutations, not even the EGFR. Right. So this is so I mean this is why I included this point, not because it is mentioned anywhere. One
Okay.
personal case, so that's I thought maybe dekhte hain if anybody
Okay.
else has that. And of
It
course,
is
if,
not that
as
it is not that uncommon to first of all, if the patient is having EGFR and then after disease progression, EGFR in majority in like most of the time EGFR 379M it can come or something like Metaxon 14 it can come. But
Yes,
all of a
yes.
sudden if it like EGFR can be lost, but there is other kind of mutations from the EGFR only it can roll down. But there is also a kind of possibility where the EGFR completely it can be lost and there will be some kind of HER2 or TP53 or RAS, something it can be popped out. It is not that uncommon. Yeah, we do see
right,
in the practice.
right, right. And the last point, of course, is what Dr. Manas already suggested, that possibly this isn't a true progression. This could be a pseudo progression, and we always have the option of waiting and watching. So, of course, these are the various reasons why we do these tests. And of course, liquid biopsy, if there is progression but no biopsyable lesion, you want to find new targets, blah blah blah. I mean, we all know, and cost. I mean, let's not just talk about the cost constraints because that's a whole new debate. But as far as this particular patient is concerned, the liver biopsy was done at this particular progression. We found a MET exon 14 skipping mutation. A MET mutation is fairly common. It is among the most common escape mutation mechanisms from EGFR targeting. And the question, I guess, suppose what would we do now? We have discussed quite well already. What my question would be, do you repeat testing at each progression for all patients? Dr. Santosh?
Usually not for all the patients, but it depends what the patient has received upfront. So,
Okay.
like if the patient has received like EGFR first generation and second generation, and then there is a disease progression, it like usually we know these kind of patients would be having T790M or something, some kind of like that. So for that kind of patients, like a simple liquid test will be like enough only for the T790M. If the patient is having osimertinib and then having a disease progression, we know we want to catch some kind of MET amplification or some other different kind of mutations. For these kind of patients, I do usually repeat the NGS testing. If at all patient is having any immunotherapy and having a disease progression, so definitely at the each point of disease progression, I will be checking whether it is a real progression or any pseudo progression, and then I will repeat for the NGS.
So Dr. Manas, this patient is Ambani ka bhai, not the. So he has solid tissue testing only, liquid only, tissue plus liquid for all.
So what if he's Ambani's bhai? So he will only tell me that I want to do tissue biopsy as well as liquid biopsy. So I will definitely discuss with it is yes we can do because it's not recommended that we cannot do. But such a short progression, I would like to add my thought that we have just completed 3 months, and if within 3 months, if it is progressing, so I would like to give a chance so that we can think about 2 to 3 months more, around 6 to 8 months, if like that. If this patient we are talking about.
But I specifically went to ask for all patients upon progression, for wherever you feel that testing is indicated. Do you ask for solid and liquid? I mean, would you prefer solid and liquid both for all,
So
or are you
if
happy
the
with
patient is
tissue testing?
affordable, yes, I will definitely add both. And if it is not, then I will personally go with the solid, because ASCO also recommended that if you have the solid tissue, then you go with the tissue. But yes, I will. If patient is affordable, I will ask, because for liquid biopsy you just have to give one more sample, blood sample, no, only.
Yeah, so I seem to find that at every single discussion like this, with
Hmm.
every single oncologist that I can find, we all seem to agree कि solid plus liquid करना तो दोनों है,
Hmm.
but कौन सा वो patient आएगा जो solid liquid दोनों कराएगा,
दोनों कराएगा.
वो पता नहीं कब आएगा. I mean, it's tough to treat these patients. I mean, in the West, I guess everything is covered by insurance and they get these things at a whim almost, I guess. And it's
Yes,
tough to
yes,
do it
correct.
in our clinical scenario.
But all solid plus liquid, sir, like if at all if you get a good chunk of tissue, like tissue is always an issue in pathology, right? So like definitely if you are okay to get a good chunk of tissue where we can have the NGS, better to stick with solid, at least tissue, and where we can't get the tissue, better to go with the liquid biopsy, and liquid NGS also would suffice. Liquid NGS also is not that costly nowadays. We have a coupon for that, so it's only 14K. So definitely patient can afford. If patient is willing for osimertinib, he can afford for 14K.
Okay.
Yeah, fair enough. Fair call. Fair call. I think that is how we seem to do our testing and everything as well. कि जब इतनी महंगी दवा लेना है तो थोड़ा सा मेहनत करके एक टेस्ट करा लो. Might well be worth your life. But for this coming to this particular case, SBRT was given to the liver as well. Biopsy had
Sorry
already
for
shown a metexon mutation. Continued on same systemic therapy for 9 more cycles, which is essentially why we do local therapy for oligoprogressive disease. We got a few more months out of this, but this time he progresses with a new bony lesion and multiple new liver lesions. So finally, the metexon 14 is now starting to show up and behaving the way the escape mutation will. And this time, palliative RT was given to the L5. So Dr. Shamila is nodding her head, so she agrees with this choice. Uh, Dr. Santosh, switch to tepotinib, switch chemotherapy as well.
sorry for interrupting. Please, we are short on time, so can we please
Yeah,
get up?
this is the last slide. I don't have anything beyond this.
Hmm.
Just one final
If,
take from all my audience panelists, basically.
if the patient is comfortable and the patient is having good performance status, even then now I want to add if the patient is having metexon 14 skipping mutation, this I want to target that, but I want to add chemotherapy as well.
Okay, fair enough. However, this patient was continued on 450 tepotinib, developed grade 3 edema, dose reduced to 225 and doing well, at least so far. Right. So, Dr. Manas, anything you would like to do differently in this scenario?
So same, I will continue with tepotinib.
Okay. I think this is pretty much everything that is practically possible to discuss in this kind of time frame. Baki these discussions seem to go on forever, so I will इससे ज़्यादा बोलूंगा तो Dr. Abhishek will be after my head. So thank you to my panelists, thank you to the organizers for the opportunity for such a lovely discussion, and over to you, Dr. Abhishek.
Thank you for this excellent discussion. I enjoyed it pretty much.
Yeah.
So we will jump to our next panel discussion. So is Dr. All the panelists are there. Dr. Swati is there, right? So I will ask her to take over the session, please, and start the panel discussion.
Good evening, everybody. So the topic for today's discussion is stage 3 NSCLC. One stage, multiple strategies. How do we choose? Can anyone play the slides, please?
Just a moment, one. Our team is sharing.
So do we have all the panelists? Dr. Sushil, who's a medical oncologist from Chhattisgarh, Dr. Vijayata, radiation oncologist from Cuttack, Dr. Hemant, medical oncologist from Andhra Pradesh, and Dr. Santosh, medical oncologist from Bhubaneswar.
Ma'am, Sushil sir is not with us due to other prior things. Rest all panelists are available.
Okay. So coming to the topic, stage 3 NSCLC is not one disease. It actually ranges from borderline resectable N2 to bulky unresectable N3. So today, the topic that we're going to discuss is where the evidence truly guides us in today's scenario in 2026. So my first question is, are we still treating stage 3 as a single entity, or are we entering a biomarker-driven era now? Dr. Santosh?
No, ma'am. Good evening. We are not treating in stage 3 as a single entity. Now it is biomarker driven. There are a lot of changes in the management of stage 3 disease.
Yes. So my next question would be, is stage 3 a surgical disease, a radiation disease, or a systemic disease, or all together?
It is altogether. It is a systemic disease. It is a we can plan for a local advancement, like you can add the CTRT. We can go for surgery as well, but upfront surgery less likely. You have to give for perioperative therapy, then we have to go for surgery for feasibility.
Okay. Dr. Hemant, my next question would be to you. So has immunotherapy changed the biology or only outcomes?
Actually, it is both the disease biology and outcomes. It's a heterogeneous disease. So if disease is stage 3, if it is resectable, it has different outcomes to be single or multi stage nodal disease.
Next slide, please. Next slide. So for a better understanding, I would like to divide the stage 3 into two parts. Let us divide it into resectable and unresectable, and then discuss the topic further. So stage 3 is definitely not a single entity. It is a multiple entity now altogether. We have now entered into a biomarker-driven era. Earlier, we used to think, या तो surgery होगा या फिर हम chemo radiation कर देंगे, but now that's not the case. The medical oncologists are somehow now at par with the surgeons and the radiation oncologists in the management of stage 3 disease. So my first case scenario would be, next slide, please. Now here, my first patient is a 62-year-old male smoker, resectable 3A single station N2 disease. So next slide. My first question would be to Dr. Santosh.
Yes,
Is
ma'am.
neoadjuvant chemoimmunotherapy now preferred over induction chemotherapy alone? If yes, what is the evidence behind it?
Yes, ma'am. I will go with the neoadjuvant chemoimmunotherapy over the induction chemotherapy alone. There are three trials, landmark trials. It is a Keynote 671. Then another IGEN trial is there. Checkmate 770 is there, and again a Nadim phase 2 is there. So all are favoring again neoadjuvant Checkmate 816 is there. Although
Right.
others are perioperative, Checkmate 816 is purely neoadjuvant. So all are favoring neoadjuvant chemotherapy over chemotherapy.
So you think in Indian scenario where there is an afford and cost issues, Checkmate 816 would be a better approach, or Keynote 671 or again, or what would be a better approach? A perioperative or a neoadjuvant?
For Indian scenario, the logistic issue, financial constraint, Checkmate 816 is preferred because to go only 4 cycles, then over. After surgery, adjuvant therapy is optional. But in other perioperative long course therapy is there. But again, it depends on what scenario. Keynote 671, again, OS benefit is there. All these factors matters to decide the treatment purpose. But Indian scenario for a financial constraint patient, Checkmate 816 is okay.
All the more reason
but
now when you have a biosimilar nivolumab.
yes, we have a biosimilar nivolumab also, so the cost also down. So in
Dr.
that
Hemant?
case, we can.
Sorry. What were you going, Dr. Santosh? Yeah, please.
Yeah, so again, biosimilar nivolumab available, so you can choose the option of Checkmate 770 as well. If Trista like some facilities available, we can choose the option of Checkmate 770 as well.
Okay. Dr. Hemant?
Yeah, yes.
So same question to you. Neoadjuvant chemoimmunotherapy over induction chemotherapy alone?
If affordability is not an issue, I'll definitely go with perioperative chemoimmunotherapy
Because of the OS benefit only?
because of OS benefit and also maybe disease biology.
But
Like some,
we had pathological response rates good with the Checkmate 816 also. Why not that?
yes, but again, in patients, maybe some patients harboring P50.
Okay, so
with
that means you want
mutation.
to go ahead
We
with
don't know
the
the
periop.
disease biology exactly.
Okay.
Perioperative.
PAT-CR is impressive, but can it be validated, surrogated for an overall survival as well?
Yes, it has patients who had PAT-CR has definite improvement in the survival outcomes actually.
No, but is it a valid surrogate? So in breast we say that yes, it is a valid surrogate, but do we take that in lung as well?
Actually, the trials are showing the same.
There is a
It's
trend.
a valid surrogate for survival outcomes.
Okay, okay. So the next question would be, is bulky N2 still a surgical disease in the IO era, or should we go ahead with the neoadjuvant approach?
It depends on the single station or versus multi-station N2 disease. If it is,
Single
if surgeons
station,
feel that
bulky
it is,
N2.
if surgeons feels that it is potentially resectable, maybe after neoadjuvant chemoimmunotherapy, definitely we'll go with neoadjuvant chemoimmuno followed by surgery. And
Okay.
then
And has neoadjuvant immunotherapy improved the resectability rates also, or is it just a PAT-CR and OS that we're talking of? Very happy with that.
neoadjuvant chemoimmunotherapy has definitely improved surgical outcomes also. I mean, there's no much difference in the, it is just a numerical improvement in the surgical resectability.
No, but the surgeons feel that with use of immunotherapy, there is increase in fibrosis. So does it cause some difficulty in doing the surgery? So we don't have a surgeon with us who would tell us. But have you ever heard of that? The surgeon saying that you use immunotherapy and we get a lot of fibrosis in the surgical field. So is it improving resectability or causing them a little difficulty?
No, I did not hear from the surgeons actually.
Okay, okay. Next slide, please. So, should adjuvant IO still continue even if PAT-CR is achieved? So, you're talking about a perioperative approach. We agree that a perioperative approach has become quite a lot of standard if the patient is affording. So, if we have achieved a PAT-CR, should adjuvant IO be continued? Are you over-treating?
Actually, that is a bit debate actually. In patients who received nivolumab in the neoadjuvant setting, continuing perioperative, I mean post-operative nivolumab, it did not show much difference in the outcomes. I mean overall survival and event-free survival.
Yes.
But pembrolizumab has done better in the perioperative setting, even in patients with PAT-CR.
Yes, that is why. But is it even required that much of over-treatment is the question.
Actually, that's a controversy.
Okay.
Actually.
So if a perioperative
Pembrolizumab has definitely improved. Pembrolizumab has definitely improved the EFS and OS outcomes. If affordability is not an issue, definitely I'll consider continuing the immuno even in patients with PAT-CR.
Okay, okay. Dr. Santosh?
Yes, ma'am.
Yeah. So you would
I
say the
would,
same?
yes, I am with sir only. I would like to continue because Pembro trial showing OS benefit, EFS and OS benefit as well. Again, it depends on the some scenario, individualized basis. Although there is no strict criteria, like if patient is N2, multi-station, T4, then I would like to complete. If stage 2, then I will discuss with the patients pros and cons, and I will decide judiciously. But in bulky into multi-station T3, T4, I will definitely like to continue.
Okay, fair enough, fair enough. So do you routinely test PDL1 before starting a perioperative IO, or it is just like a go that we just start like a neoadjuvant therapy?
Actually, the benefit is both irrespective of PDL1, but in our institutional practice, we are doing PDL1 before starting the therapy. At least ALK, EGFR, and PDL1. It is a institutional protocol before starting therapy to complete it.
Okay, okay. So you do test for PD-L1. So have you
Yeah.
seen any difference whether the patients with negative PD-L1 responding poor or the patients with positive PD-L1 responding in a better way?
Although trial showing there is no much difference, but in clinical scenario we have only 4 patients. We are observing that those who having PD-L1 more, CP score more, they are responding little more. Although yeah.
Okay. Next slide, please. So this is just a summary of the IO trials that we have discussed during the previous lectures as well. IMpower, Keynote, Checkmate, AGAIN, NeoTorch. Almost except Checkmate, that was in the neoadjuvant setting, all the trials were perioperative, peri-adjuvant and adjuvant settings, and they have definitely shown improvement with the Keynote trial with the pembrolizumab showing a overall survival improvement. So I do agree with the panelists that yes, we should be offering a perioperative approach if the patient is actually affordable, because indeed it has given a OS survival benefit apart from the PAT-CR and improvement in the resectability rates. Next slide, please. Next slide, please. So we've discussed this already. So just a framework of the trials. So if we are having a targetable mutation, as Dr. Santosh and Dr. Hemant have already said, that they test for an EGFR and a PD-L1 before starting any treatment. So we have a ADAURA trial also that says that adjuvant osimertinib, and ALINA trial that says adjuvant alectinib in the resected patients. And we have already discussed the IO trials. So next slide, please. Next slide, please. I will jump to the next case now. Next slide. Yeah. So the second case scenario is, now again, we have a 62-year-old male, stage 3A, but N2 disease, which is unresectable, with a PD-L1 60% and EGFR wild type. Next, please. So what defines unresectability in a stage 3? Is it anatomy, biology, or institutional philosophy?
It is mostly anatomy as well as depending on the surgeons also. If it is multi-station bulky N2, definitely encroaching the vessels, so it is radiologically and anatomically unresectable. And again, it depends on the surgeons also sometimes.
So basically, it is all anatomy,
Yeah.
institutional physiology, and somewhat biology. So N3
Biology.
disease, bulky N2, multi-stations,
Yeah.
and institutional practice depending upon the surgeon.
Yeah.
Okay. So next question. Next slide. Yeah. Next slide, please. So this question would be to Dr. Vijeta. Is concurrent chemoradiation still the standard backbone, or is it sequential acceptable?
Definitely, you know, the standard of care after the 94 9410 trial is definitely concurrent chemoradiation with double platinum to dose of 60 gray. Sequential, I would still consider in a select case of patients, provided you assess the ECOG1, you find the patient and having an old age, but not the number, I would say, the biologically, how, if the nutritional quality, any pre-existing comorbidities which would hamper the further sequence of therapy. In that cases, I would like to consider sequential therapy, those select cases. Otherwise, the standard of care is concurrent chemotherapy.
Okay. So fair enough. The standard of care remains concurrent CTRT with the platinum doublet to a dose of 60 gray. Sequential, yes, frail patients, elderly, where we think that the combined treatment modality would be unsuitable or the patient would not be able to tolerate. Probably bad PFTs also. So that is a case, or frail elderly patients, I would say, in a better way. That is a case where a sequential is still acceptable. Apart from that, concurrent chemoradiation in an unresectable stage 3 patient is still the standard backbone. Next slide, please. Next. So my next question would be role of consolidation immunotherapy to Dr. Santosh and Dr. Hemant.
Yes, ma'am. If a patient is on concurrent chemoradiotherapy, After completion of chemoradiotherapy, we reassess the patient. If patient having complete response or partial response or stable disease, and within 6 weeks, day 1 to day 42, we can give the option of, if there is no EGF driver mutation, we can give the option of consolidative Durva
So based on
for
the
1 year.
Pacific trial.
Pacific trial for the
Based
1
on the-
year.
Yes. So there was an overall survival improvement with use
Yeah.
of durvalumab as a
10
consolidation
milligram per kg.
immunotherapy in patients who had no progression on CTRT. So, but are you going to consider consolidation immunotherapy for all the patients irrespective?
No, ma'am. Those having the driver mutation, we can't give the consolidative immunotherapy. So we have to rule out patient having driver mutation or not. EGFR, especially EGFR and all should be excluded.
Yes, EGFR ALK patients should be initially, when the trial was started, they did not exclude the EGFR and ALK patients. However, during the course of the treatment, they realized that the patients, as in the metastatic setting, patients with EGFR and ALK do worse with use of immunotherapy. That's the same in the adjuvant and the consolidation setting as well.
Yeah.
So all patients should not receive durvalumab after CTRT. The patients who are EGFR and ALK positive should indeed not receive durvalumab after CTRT. So one thing. So was this benefit? So PD-L1 threshold. So there is a little difference between the US FDA and the European agencies. They say that the PD-L1 more than 1% was required. However, FDA says the benefit is irrespective of PD-L1. You should use in all the patients. So do you have any take on that? Was that even justified? Because the trial itself said that the benefit existed irrespective of PD-L1.
Yeah, PD-L1. So there is much difference, ma'am. So I would go irrespective of PD-L1.
Okay, okay. Next slide, please. Next slide. So again, what about EGFR mutant patients now? So
yes, ma'am. If patient received the CTRT and patient having the EGFR mutation, and after reassessment within 6 weeks, if patient found complete remission, partial response, or stable disease, not progression, then we can have the data for at least osimertinib for from the LAURA phase 3 trial for till progression. There is no definite period like adjuvant setting. It is 3 years, but here it is not till progression. We have to continue.
okay, Dr. Hemant, I would like to ask one question. So after CTRT, if we go ahead with 1 year of consolidation durvalumab, have you seen any incidences with higher pneumonitis risk compared to the patients who had not received this in the consolidation setting?
Yes, I have seen a higher incidence of pneumonitis after CTRT in patients who received durvalumab as a maintenance.
So how much percentage of higher pneumonitis risk?
Maybe around 10 to 15%.
So you people, at what grade of pneumonitis will you stop?
Increase in the risk of pneumonitis with yes.
So you people stop giving immunotherapy after a grade 2 pneumonitis or a grade 1 pneumonitis sets in?
Yes, in pneumonitis, even after grade 1, we need to stop immuno.
Okay, okay, fair enough. So one thing, yes, we are giving consolidation immunotherapy, but one thing that we have to keep in mind is the patients have already received CTRT. Radiation to the lung itself has some risk with pneumonitis. However, giving 1 year of adjuvant of durvalumab will indeed cause a higher pneumonitis risk. So, Dr. Vijeta, how do we differentiate whether it is a radiation pneumonitis or an IO-induced pneumonitis? Are you there, Dr. Vijeta?
Sorry, am I audible now?
Yeah, you're audible. So
Yes.
how would you differentiate if it is a
Yes, yes,
radiation-induced pneumonitis or it is an IO-induced pneumonitis?
The very first thing clinically per se to come in mind is the onset. Radiation pneumonitis usually starts after 1 to 2 months completion of RT, whereas
that is the time immunotherapy also can happen.
Yes, but usually immuno can even occur even months after or even any time during the immunotherapy. Whereas radiation pneumonitis during treatment, it is usually rare as per conformal techniques are concerned, OR constraints are met. Usually it is not encountered. Secondly, radiologically, you find it, the opacity is usually in the field of radiation, It is usually conformal, not patchy or diffuse. It is usually confined to the field of acti, the consolidation. And
So unilateral versus bilateral.
definitely unilateral versus bilateral. And you give a low dose of steroids, it is usually cured, and it rarely requires higher doses unless the grade is accentuated for any untoward consequences.
Okay, true. Dr. Hemant sir, radiation versus IO-induced pneumonitis. Dr. Santosh?
Actually, she pointed out the correct points only. Radiation, radio-induced pneumonitis is confined to the radiation field, but IO-induced pneumonitis is bilateral, diffuse, and radiation pneumonitis again the fibrosis is extensive and it is confluent. But in the IO-induced, it is patchy. It is just follow the Miller TB-like pattern. What could I say?
Okay. Next slide, please. So should every stage 3 patient now undergo a comprehensive NGS before starting CTRT, or it is just EGFR, ALK, ROS, or probably PDL1? The way we started with the stage 4 lung cancer. Initially, we used to do only EGFR, ALK, ROS.
As of now, we have data for only EGFR, ALK, and PDL1 testing.
Okay, sir. No comprehensive NGS testing. So you recommend that, or you would say that only EGFR or ALK would do?
Yes, it's a focus.
Okay. Dr. Santosh?
Sir only. Hemant sir.
Okay. So you will not offer also an NGS before starting CTRT?
Limited NGS, I would like to say limited NGS. If feasible limited NGS, we are offering.
You're offering limited. What sort of limited NGS? It should definitely
like
include EGFR, ALK,
EGFR, ALK, and PDL1. That three must be included.
That is it. Okay.
Yeah.
Agreed. So as of now, the data exists only for EGFR, ALK, and PDL1. However, as we have progressed in the stage 4, we do hope that a comprehensive NGS would soon become the standard of care before starting the treatment in stage 3 also. Next slide, please. So Abhitak, we have just understood that one size does not fit all. Stage 3 is definitely a very heterogeneous entity that can be treated in multiple ways, can be divided into resectable, unresectable, resectable also, upfront resectable, or potentially resectable patients. We can have the treatment management strategies difference among both of them also. Next slide, please. Now we have a stage 3 patient, unresectable, PDL1 say 40%, EGFR exon 19 mutant. How would you proceed?
So definitely we should go for CTRT followed by adjuvant osimertinib for an unlimited period of time till progression or unacceptable toxicity.
Okay, sure. So, but with the LAURA trial data now on osimertinib, should we totally abandon durvalumab in EGFR mutant disease? Because initially, when the Pacific started,
yes,
it had EGFR mutant patients as well.
But again, we have the risk of pneumonitis.
Yes, that we have with immunotherapy also.
Yeah.
And that we have with osimertinib also.
Yes.
Because the LAURA trial OS data is still a little immature, but there is a PFS benefit definitely.
But I will like to add that in the Pacific trial, in the subgroup analysis, there has been no benefit of the patient who are EGFR positive. So probably
Yes,
in the
that's what when they did retrospective analysis, that they said that in the subgroup analysis, they said that EGFR positive patients, it actually did worse with use
Right.
of immunotherapy in that scenario. That is where when the LAURA data sets in, that yes, if it is an EGFR mutant patient, it is a TKI disease, not an IOIO disease.
Right.
And yes, CNS control, pneumonitis safety profile, they're all better with the use of TKI compared to the use of immunotherapy. Okay, next slide, please. Next slide. Next. So, does PDL1 guide therapy in stage 3? We've already discussed that it doesn't. The use of PDL1 is, so we see that it is better with the PDL1 positive patients, but irrespective of that, we can use it and we have seen the benefits. My question would be to Dr. Santosh, is TMB still relevant? Like we have the use of PDL1. PDL1 is not guiding therapy in stage 3. Use of tumor mutation burden, is it there anywhere?
I think we are running short of time, so people have already left. Sorry.
It's okay.
So probably, so I think I can answer this. So I think TMB probably not in the early stage lung cancer. I don't consider TMB as a relevant marker. I do consider obviously PDL1 probably we do it, and we can also do probably an NGS as we have already discussed. But right now TMB do not have as much relevance, especially in the lung in the early stage.
Okay, true, fair enough. So next, I would like to go to the last slides actually. So where I have made the treatment decision points, the treatment algorithm. Next slide, please. Can you jump up to 3 or 4 slides? Because of the lack of time. So simple thing. Next slide, please. So treatment algorithm for an unresectable stage 3, diagnose, check the fitness. Yes, go for concurrent CTRT. Check for driver mutations, at least in EGFR and ALK. If yes, go for osimertinib consolidation. If no, go for a durvalumab consolidation. We still don't have a data for ALK. If unfit, sequential CRT, consider durvalumab. Next slide. If it is a resectable patient, so again, assess operability, lobectomy feasibility, limited or bulky. Yes, neoadjuvant chemo-IO is now the standard of care, followed by surgery. If no, then treat as unresectable. Otherwise, post-op adjuvant systemic plus minus radiation plus minus immunotherapy is the go-go thing now. So yes, that would be it.
So thank you very much. I think this will be the end of the session, and we had a very fruitful discussion right starting from the early lung cancer, and we discussed all the new trials. Now we had a very wonderful 2 panel discussions, and I would like to thank all my faculty members and all the attendees, as well as the IOI team for providing me this platform. Probably we will end this session right now because of the paucity of the time, and we will probably join in the future. Thank you, everyone.
Thank you, sir. Thank you so much. So as we come to end of this session, I would like to extend a heartfelt gratitude to our program director, Dr. Abhishek Tiwari, sir, and all our esteemed speakers and panelists, and each and everyone for the active participation. So before we conclude, I just want to say there are upcoming sessions under the guidance of Abhishek Tiwari, sir, in the upcoming months. Hope everyone will register and join the same with the same enthusiasm. Over to you all. Thank you so much. Very good evening. Thank you, sir. For all the participants, the certificates will be issued in 3 to 4 working days. Thank you.